founder-led, minority-led nonprofit for medical advancement, and we provide these free pre-health shadowing opportunities and many more to students in need. So we do have closed captions to accommodate all students in all needs. And also, if you want, you can email us at info@prehealthshadowing.com to save us as a contact and to join our email list so you never miss out on a new session or another opportunity. Apart from our email list, we also have a bunch of different social media. We have Instagram at Prehealth Shadowing, and we also have TikTok at Prehealth Shadowing. And on here, we just post like upcoming sessions, upcoming opportunities, and different things that you guys might be interested in. So because we are virtual, we want to know where is everyone calling from. PHS headquarters is in California. And so if you guys could just type in the chat where you guys are calling from, that would be very helpful. So we could just grasp where our students are coming from. Orlando, New Jersey. New Jersey. I'm actually calling in from Canada, so I'm in a completely new country than you guys, but I guess we're pretty close. So if you're interested in actually being a part of pre-health shadowing, you can join as a student volunteer on our website. So something like what I'm doing right now as like a volunteer as a host for sessions. You can also volunteer for many other things. You can also become a team member. This is just the main difference is there's a bit more dedication as a team member. And there's also, we have a bunch of leadership roles, so you can help join our leadership team. It's 100% remote, and you can apply online today through our website. And I'm sure you guys have our website because you probably access the Zoom through our website as well. And so some leadership roles within PHS, we have things like the IT department, lead of grants, research program, lead of diversity and inclusion, and many more. And you can also feel free to reach out to us and suggest something that you think pre-health shadowing should add. You can even create your sort of like own leadership roles. And if you are a high school student, sometimes we get high school students calling, joining our sessions. So if you are, there's something called the High School Training Program. And it's a place where you can start a club at your high school and gain leadership and also bring this program and this nonprofit into your high school. And so you can also sign up for that through our website. And also because we are student run, we are a nonprofit, and we want to keep our program free and accessible to everyone, we do ask if you can donate, please donate. And if you can't, please like send this link or send the QR code to someone else that you know who may be able to donate. We need these fees to like keep our Zoom running, our website running, and etc. And we really appreciate like even if it's just a small amount. And throughout the session, there will be a Q&A, like about 30 to 40 minutes of question and answer in the end, where you'll get to ask questions to our professional and they will provide us answers. And so you don't have to like hold on to all your questions. Feel free to just dump them in the chat. We have other volunteers and myself to keep track record of those questions, and then we'll ask them later. And also take good notes because we will be giving out shadowing hours in the end through a quiz on our website. Make sure to take good notes and so you'll be able to pass the quiz. And we'll go more into about what the quiz is like in the ending slides. And yeah, because we are virtual, we do ask everyone to keep their cameras on. If you do not want to for some reason, then you don't have to, but it obviously creates a more inclusive environment for everyone. Yeah, and that's the end of our start presentation. We can welcome Karla, and she's going to go over what she has to talk about.
Hi, thank you for inviting me for this session. I really appreciate your invitation, and I hope I can share my story and how I came to be a doctor and a researcher too. So I'll share my slides. Can you see my slide?
Yeah, I can see your slide.
Okay. Okay, well, I'm from Mexico, originally from a place called Texcoco. This is an ancient view of where I am from is from Bali in Mexico. It's a very well known because it was pre-Hispanic era. It was a very great empire, and it was very rich and it was famous because of its lake. And if you know some of the history of Mexico, we used to have this our houses. Well, the houses used to be above the lake, and they have a very good system of how to live within the lake, over the lake. But it was really good. Since I was very little, I was dreamed to be a doctor. It never changed. I always knew what I wanted, and that's what I aimed for since I was little. And yeah, I am part of a big family. I have five siblings, so yeah, you can imagine. So yeah, in Mexico we have two options that are private and public schools, like at any stage. And some of the best universities are actually public, and one of them is recognized all over the world. It's called UNAM, and we actually have a university city where this college is, and we have different fields where you can study there. I actually applied for all these three different college for medicine, and where like as in any other part of the world, it's based like it's based on demand. So medicine is one of the highly demanded careers, and for if you want to study in the best university, you have to have like a really like almost perfect score to get into the college. Um, I got to one, like I didn't get into UNAM, which sadly it was at the moment it was a sad news for me, but it happens to everybody, you know. I end up entering into my college, my alma mater, that is the Mexican Faculty of Medicine, and this is a school that is a private school, and since I was the only one studying medicine and actually studying in my family, thankfully my dad was able to pay for my education, and I am very grateful for that because it's one of the best universities for medicine in Mexico. It's also highly recognized. And funny enough, all my teachers in my medical school are also teach in UNAM, so I didn't miss anything. So that's a win-win situation for me. So yeah, I studied medicine. Sadly, during my college years, in university, when I was in university, I got really sick, and it was really difficult for me to manage at the time, like being sick, and also trying to finish college. But actually, it helped me because it helped me to keep my focus, you know, in getting my degree and getting what I really wanted. So, and I actually performed really well during my last years of my career. And during that time, I realized that I didn't want to burn myself, because at some point, you know, we all love what we do. We all love seeing patients. We all love being part of being a doctor. We all love all of this beautiful career and this beautiful art of being a doctor and taking care of others. But at the same time, it gets really tiring, and sometimes you forget about yourself, and that happened to me during my internship when I was just working nonstop and not actually sleeping for 3 days. And it was you know, when you're working in a hospital and a very stressful environment, sometimes you stop forgetting what you really are in for, no? So I really have to sit with myself and think, you know, what I really want. Do I want to keep on like this, burning myself every week, not having enough recovery, and just not loving what I really like anymore? And I was like, okay, I think I need to decide what is good for me. I knew, like, when you're doing your internship and when you're doing your rotations with different services, um, I started to realize that I really needed something that it was within what I really wanted in terms of what I want to do with my patients and what I want to dedicate my role. And neurology was really calling for me at the same time, but also one of my friends, like what also was with me in medicine, he told me about genetics, and I was like, I didn't know at that time that it was like an option for me or for us as a specialty. So I was curious about genetics, and then I started to ask about how was this, how was that about how a geneticist is what a geneticist do. Um, so I got in touch with all my professors at my faculty, and they offered me to have like a small rotation in the genetics department to see how I feel about it, how I find it, like in terms of like if I am going to decide for a specialty, if that's going to be suitable for me. So I did that for a month, and I fell in love with genetics. So, and I say, this is for me. I don't have to, not sleep for days and not like, being mad working around the hospital. So, and I just thought that was a perfect fit for what I wanted. So yeah, and during that time, I also started thinking like I really don't want to stop at residency. I want to do something else later, and I always liked German as a language, and I always admired Germany because I just think they have a very good culture and education. So that's why I decided to learn German. I learned English since I was very little from elementary school, so that wasn't an issue for me at that time. So yeah, learning languages actually helped me a lot. So I decided to go into genetics, and I was like, okay, that's a specialty doctor. It's very interesting because we learn about genes and how they are related with our own health and how they relate with families and how it's inherited, some traits and some diseases and everything that we need to see with the families now. We help diagnosing and managing genetic disorders and conditions, but also we need to know about differences, what has an environmental component and what is true genetic component, or what is both. So that's why it's amazing about genetics. We see all ages. We not only see one patient, we see also the families, which is, I think, is fantastic. And we have different roles. It's not just clinical. Well, there's a lot of clinical part of our portion for genetics, but also research. We have to know about laboratory testing, like why you need to order a specific test, why you have to order maybe not genetic test, but I need like this specific imaging for this specific diagnosis, and also the interaction with the patient. When you after you get a diagnosis, or like before getting in a diagnosis, start with the counseling and explaining all the process that is uh, um, taking care of them for whatever they come to see you. Um, okay. So in Mexico, after I finished, I forgot to say this, but in Mexico, I was still finishing my undergrad degree in Mexico, and I decided to be a geneticist. And you also have to go to different exams. So that's also a selection process. And at that time, there were only like 30 spots, national in the whole country for being a geneticist. I thankfully got my spot. I competed with 5,000 other doctors. So yeah, it's highly competitive. So yeah, I was really glad about that. So, and always, all the time, I was thinking like, I keep in my head, my focus, and I was already, working for my aim. And yeah, and we have, but not very many hospitals in Mexico where you can do your residency for genetics. It's maybe I would say 7 hospitals, maybe now are more, but yeah, there are not that many across the nation. So when you're a geneticist, like it's very important, like something that you learn from in medicine is like how to take the history, how to do the physical examination. But that's something that I learned when I was doing my residency during my first year. It was something that is like really, really important because sometimes we don't take a lot of um, we don't think about the importance of this, and because certain clues during the consultation, that when you start the interrogation, they are the main things that are going to help you with the diagnosis, even from the first time that you see the patient. No, like when you do a good medical history, why is this patient coming from, who is sending them, like from that you start your detective work. The family history is very important. If you can see, this is a tree. This is a really easy one, to be honest, because usually it doesn't look like this. It's more complicated than that because, sometimes they are married to 3 different people, have like 18 different siblings, and it gets complicated. So even this, like doing the genetic tree, the family tree, it's really complicated. And how to code it is also it's something that you need to do as well, because how you, like, what does the circle means, what the rectangle means, and what everything, like what different symbol means. So yeah, this is actually a very good family tree for example, in this case, a dominant disease. Usually the one when you have like this, the full color rectangle or circle, it's a disease person. And if you see that in 3 different generations and consecutive, is most likely to be a dominant disorder. Yeah. But we'll talk about that in a little bit. Yeah. Also pregnancy history. Like as I was saying, not everything is genes. Like mom took something when they were pregnant. When did they take that specific medication? Was it during first trimester, second trimester, third trimester? Is that something that is related to what I'm seeing? Is like I'm seeing like they have like this brachydactylia. Has that been reported with brachydactylia? Does that make, it's something that you need to start building on, and just making everything your key points during the interrogation and your consultation. The neonatal history is super important. Like, did the baby cry? Was it like a weak cry? How was it? The movements were a little bit slow. Did they have like hypoglycemia, hyperglycemia? You start collecting these different clues. Developmental history is also, like, all of them are very important, because from there, like if you have a baby, like if the referral is coming from because they have suspicion of muscular disorder, like how when did they start sitting? When did they start like holding the head? Like, was it late? Was it like was it hasn't happened? So yeah, most of the neuromuscular disorders, from the developmental history, you can start thinking what can it be. So also photographs are different. Like if it's different if you are seeing a baby or if you're seeing an adult. If you're seeing an adult, sometimes like photographs are very, very helpful, because the face, sometimes with some syndromic conditions, tend to change. They don't seem to be like when they are small, like little infants or toddlers. Uh, they can have like very different features, whereas compared to like older ages. A very good example of changes that you cannot see when they are older, and they are very good clues for diagnosis, is a syndrome called Noonan syndrome. And this, for example, if you don't catch it on time, it can be undiagnosed during time, because they start to lose those phenotypic characteristics that helps you with the diagnosis for this specific disorder, for example. So that's why photographs are very helpful for us too. Also, the behavioral phenotype. This is very helpful also if you suspect autism. Like when did they start clapping? Like if they have repetitive movements, like do they are those noise bothers them in a way. Like you have to be very careful when you are asking for these different things: vision, hearing, if they have seizures, and some other questions that that you can come when you're doing your integration, that might also be very helpful for the end of diagnosis. As I was saying, that's an art. You go from the integration to the physical examination, and when you are collecting your interrogation, you start thinking, and then your physical examination can also be helped by what you already gather from the information you get from the integration. So yeah, you have to be very descriptive. How about the eyebrows? If it's the forehead too high? Is it too short? Is it too narrow? What is the shape of the head? Like how many teeth are missing, or they have supernumerary teeth? Like things you need to like really be very descriptive from tip to toe, because that's something that also help us with the diagnosis. Yeah, that is morphology is also like an art. Uh, Further investigations after you finish your whole integration, you review the whole medical history, you review your physical examination. So what do I need for making a diagnosis? Do I need more imaging? Do I need an X-ray to see bone age? Do I need MRI to see if they have like a problem in the brain? Or do I need more blood tests? Do I need to do a specific genetic panel? What other evaluation do I need to make a complete diagnosis? As I was saying, it's very important to have like a very good knowledge of what is normal at different stages for our examination, because if clues can be missed, and if we miss those clues, we are going to miss a diagnosis. And if we miss the diagnosis, the management will be also wrong. And as you always need to know that this is an acquired skill. It takes years to develop confidence to come up with a diagnosis, and even more to really know when you don't have a diagnosis. It's hard. Believe me, it's hard. It's something that you have to build on different, like even after finishing residency, it's something that you need to continue building up. So one of some of the good examples and some conditions that we see, and these are not examples that you can see anywhere in the web. So these are three different conditions that are very common. All of them are dominant autosomal dominant conditions. No, this is a chromosomic disorder. This is Down syndrome. That is one of the most common chromosomic disorders. They are very, very characteristic phenotypic features: the tongue, the hypotonia, the eyes, the microcephaly. Then we have here Marfan, that is very, very, they vary within different patients, but yeah, most commonly you can suspect if you have a very tall individual that has no dactyly, that's like very long fingers. Also, they can have different skeletal anomalies. One of the most common or more characteristic is that this pectus excavatum, the sternum tends to be towards inward, going inwards, and problems with aorta. That's what actually kills them, the problems with aorta. If you miss them, that can actually be fatal for these patients. And this is also another one that is very common. It's called achondroplasia. It's also a problem with the skeleton. And yeah, as you can see, the short limbs are the most striking features, and also because of disproportionate head size and torso and limbs. So you can see that this is also a dominant condition. So the diagnosis is very important because you want to give a very good genetic advice, also a good counseling. Also, with this, we can have very idea of the natural history of the disease if it's very well reported. Now we know with, for example, some conditions that need management with treatment. For example, Down syndrome, you know, they can have heart issues, they can have thyroid issues. So that because it's very well reported, then we know that we need to do screenings every year and check up that everything is going fine with them, so that we don't miss anything. Then they can be managed and have a very good prognosis. Uh, that's why we surveil them. No, it's targeted depending on the condition. Sometimes, depending on the disease, we also can provide prenatal diagnosis. And that this is sometimes a bit controversial. Not It's not available for all conditions, and that needs to be reviewed case by case. But yeah, that can be also available. Also to provide better support for the family and the patients. Yeah, it's very important to have a correct diagnosis and also check with the family how are they, because sometimes we don't think how that can impact the families. Now you give a diagnosis and you don't know what they would be thinking. Most of the time they start feeling guilty and thinking that it's their fault or something that they did wrong, and that can be very, very um, problematic. If you need to be good at assessing these situations, so you can refer them uh, in a very timely manner to every service that they need to see. And if they are not ready for the counseling, that you can continue seeing them and continue assessing how they are at that point. As I was saying, we see different types of disorders. I'm going to just say a few. We have different groups, and depending if it's a Mendelian, if this follows these laws, that we have like something that is dominant. It means that one of the allele that is inherited, if you are inherit that allele, you will be affected. And if you don't inherit, that you're good, because one allele comes from dad and one allele comes from mom. Each of them have both. So yeah, if they have 50% chance of inheriting the disease allele, of the disease with the allele with the disease. So that's why the 50% comes from, and it's usually it's not like you have 10 kids and 5 are going to be having the disease. It's in every pregnancy, this is a chance of them having a baby with a disease is 50%. We also have something like the inheritance called autosomal recessive. This is a 25% of inheriting the disease. It means that both parents are carriers, and there's a chance if the baby has both alleles that have the disease, then they will have the disease. And there's also a chance that baby can be a carrier. One common condition that is a recessive condition is cystic fibrosis. It's a very, very common one. And there are many other. Metabolic diseases are a very good example of autosomal recessive disease. Then we have X-linked, and that's mainly related to inheriting a disease allele from chromosome X. And yeah, that's also like that can also inherit that X-linked can give that disease allele. Mom. Then we also have non-Mendelian disorders, that one of them is Some of them are called imprinting. That means that's a different mechanism of disease. It can be also mitochondrial diseases. That's also another way of getting the condition because mitochondria are inherited only from mom. There are other called trinucleotide repeat disorders. A very good example of this is Huntington's disease or X-Fragile. And we have other polygenic disorders. One of them is deafness. Deafness can be polygenic and multifactorial. Some of them, genes and environment and other unknown factors can be contributed for the disease, like diabetes, cardiovascular disease, and so on. So after finishing genetics, you have also the option to go into another subspecialty, like with other specialties. You have the option to do neurogenetics, oncology, metabolic disorders. As I was saying, this is a very good one. I actually was very interested in pursuing my career in metabolic genetics. I did several courses with different institutions, one in Colombia and one in Chile, and they were really good. You can also go into perinatology. That's basically mainly for prenatal diagnosis, helping moms start during, or like fertilization issues and those family planning, all of these situations. Ophthalmology, there are a lot of genetic conditions that can be expressed only by eye conditions, like glaucoma is one of them. There is a condition called aniridia and some other that are really like blindness also has some genes are related to blindness and research. I'm sorry, I'm having a really hard time with my throat. And research, you can also go into more basic research if you want. And this is a karyotype. When I finished my degree in genetics, I was working reading karyotypes and also doing some fish. This is an example of a fish. This is a very good fish about, if you can see it, they have probes that go to a specific region we are interested. That is to diagnose some conditions. Some of them are like localizing the centromere from the chromosome. This is in the green one is a centromere probe, and the red portion is the portion that we are interested on, and this means that it's present in this chromosome but not in this one. So as I was saying, you have a pair of chromosomes, like for example in this one this is a chromosome 7, and it is missing a part, this red part on the chromosome, and you cannot, because of the size of the deletion in this case, you cannot see it in this way. That's why you're looking in a fish. These are like a little bit older because now we have next generation sequencing, whole exome sequencing, some of those, but it's very good to know also these different techniques because they can be also helpful when you don't have these other diagnosis tests. So yeah, I wanted to do more research because when I was doing genetics, I realized, most of the time is you have a diagnosis, you have like the natural history, you know what is going on at that time, what you're looking for, but you don't have a treatment. Or sometimes you don't have the diagnosis on the right time then for them to get a proper treatment. And a good example of that is all these metabolic disorders like phenylketonuria, galactosemia. If you miss the diagnosis, you miss the treatment, and if you miss the treatment, these patients die sometimes. So that's what I was thinking at the moment that I finished my specialty degree, and I was thinking like I really want to do more research because we need better diagnostic tools, we need better treatments for the genetic disorders. I want to do like more. I don't want just to um, not continue doing anything to improve their lives, the quality of life of my patients. So as I mentioned, I learned German because I always wanted to go to Germany, and I applied actually to the Max Plan. I got rejected, of course, and I thought like probably I do something else. And one of my friends told me, you know, you already know English. Why don't you apply to the UK? They have very good programs in there, and we have these very good scholarships that they give. And if you get into the school or the college or the university, you don't have to learn something else because you already know English. And I was okay, fine. I'll try that. And if it doesn't happen, then it's fine. I mean, I have plan B. So yeah, I thankfully I applied to these three different universities. I really like the program. I really went in through all of them, and I say, okay, molecular medicine is for me. This is what I want to do. So I applied, and I got into the University of Sheffield, Queen Mary, and Trinity College. And that's when I tried in Mexico, we have a very good scholarship that is from this fund, Science Institute, that is a CONACYT. So I applied for that scholarship because that will be will be covering the fee for the university, and also gives you fund for living, cost of living there. And I got it. So I was okay, fine. This is good. And my plan was I'm going to just do 1 year of master's, and then I come back to Mexico, apply what I learned, and then I continue working in Mexico. Yeah, I did my master's in molecular medicine. I was interested in oncology, particularly in breast cancer. Sorry. And because one of my family members, she died from breast cancer, so I really wanted to do something in that area. So I went and I applied for that particular path for molecular medicine. But the other ones were also very interested in proteomics, genetics, and neurosciences. My project in breast cancer was made, breast cancer is one of the most prevalent diagnoses and cancers in women. There are different risk factors like age, lifestyle, diet, hormones, family history. That's one of them. Like in genetics, we see patients with BRCA mutations. That is one of the most common ones. There are other genes that are related to breast cancer, BRCA1 or BRCA2. P53 is one of them too. ATM, and there are a huge number of genes related to breast cancer. This also it is a multifactorial disease, and as I said, there are different factors here that are involved in the disease development. So the genetic mutations combined with environmental factors and other epigenetic factors are all the perfect combination for developing the disease. One of the problems is that most cancers, not only breast cancer, but many cancers have developed this resistance to drugs and radiations. And that's one of the main challenges that we're still facing now. Because it's also the cause of the mortality. So as here is like a brief diagram of how it happens. Like you have a normal cell that it goes through unknown changes. We still sometimes don't know what is going on here. Then from a normal cells, it becomes an abnormal cell. It still doesn't look like abnormal, but it has started to have genetic alterations that are starting to change into a premalignant cell. And then we start having changes like breast hyperplasia, and then that's when everything develops with the different combinations of epigenetic and genetic alterations and go into malignancy and then developing cancer and metastasis. So in my specific project during my master's, I was mainly focused in looking into hypoxia. Hypoxia is one of the main features for drug resistance in cancers, mainly in breast cancer. Here we found that for about 40% of these cancers that are drug resistant are extremely hypoxic. And one of the main genes involved in hypoxia is called HIF-1 alpha. This is one of the main regulators of angiogenesis, and that's tumor adaptation under different stress conditions. And yeah, normoxia is when you have a concentration within the tissue above 5%, usually around 9%. And yes, HIF-1 alpha has different changes and is also different ubiquitinate, like marking that protein is what it help HIF-1 alpha getting into different stages, and it depends if it gets degraded or it gets involved with it another protein or different factors. It's very basic, but yeah, that's mainly what I was using. And so it's also a little bit complicated diagram, but I'm just going to say hypoxia. This can when we have hypoxia levels, we have what happening is it's preventing the activation of one of the hydrolases and ubiquitination. Those are just molecular markings. So by doing that, it prevents its degradation. So if it's not degraded, it start to express hyper express, and also get dimerize in the nucleus with this HIF-1 beta, and then get this HRE that is his hypoxia response element. All of these are genes that go into the nucleus and then get once they are in the nucleus, they start triggering other genes to start having more angiogenesis. That means more cells, more vessels, enhancing the metabolism of their glucose and their transportation, production of erythropoietin, cellular proliferation, and then that's when everything starts to work they start having more cells and proliferation and invasion and metastasis and preventing apoptosis. So yeah, and then start producing more reactive oxygen species generation, and that's what's starting to trigger other instability within the genome, damaging the DNA, and that's a cycle that repeats and repeats and repeats. And there are other growth factors that also contribute to this cascade of events, cellular events in tumors. So that's one. Our theory for that project, it was that histone deacetylase that we call the HTAGs can help from preventing that happening, like especially in cells that have these resistance features, and indirectly inhibit an angiogenic response of this breast cancer under hypoxia. And yeah, that was my project during my master was to treat different breast cancer cell lines. Some of them were like a normal, like metastatic breast cancer cell lines and non-metastatic cancer cell lines. So we were studying normoxic versus hypoxic conditions and see whether that can help like preventing the cascade that we were seeing third HIF-1 alpha stimulation. It was a 3-month project. So I didn't have enough time to do that, but we have promising results. It seems like HIF-1 treating cells with HTAG inhibitors can prevent the hypoxic levels to reach uh, uh, that level of triggering surviving cells, mainly to breast cancer cells that are resistant to radiotherapy and other drug treatments. But more work needed to be done, more assays, more Western blots, more genetic profiling, studying different cascades. One of them was apoptosis. So yeah, we didn't have enough time for that. So when I finished in the UK master's, the master's program is just 1 year. So when I finished my master's, I got an offer for a PhD in neuroscience. So I end up doing and if my PhD in neuroscience, not so much cancer, which I think it was funny at that moment. But yeah, I stay in the University of Sheffield. I got more funding from my scholarship from CONACYT. So I did my PhD. My main focuses was in this gene called Tiger in Parkinson's disease. Um, but we found our group. We found that this gene called Tiger was overexpressed in animal model, zebrafish model for Parkinson's that had mutations in Parkin. They found that Tiger B was overexpressed, and that was leading to disease phenotype in the zebrafish. So one of my main projects was trying to find out if that was true also in the brains of humans, like from uh, pathology brains. We didn't take any brains from any human. It was from the brain bank. So yeah, we examined all these brain tissues using not with only Parkinson's disease, but also similar disorders like dementia with Lewy bodies and having controls. No? So this is an example of how does it look like substantia nigra. This is a midbrain where you can see all the neurons that are mainly involved in Parkinson's disease. So this is an example of how the dopamine looks like in a brain tissue. These are a neuron, and as you can see, this is the substantia nigra. These are controls. These are brains from control patients. They didn't have Parkinson's. This is substantia nigra, midbrain also, but this is from a patient with Parkinson's disease. This is a Lewy body. If you can see it, here's a lubricant Haynes. This tends to be a little bit round. Here's another one. If you can see, those are inclusions. And there are this pathognomonic of Parkinson's disease and dementia of Lewy bodies. Then it's very simple. We stain these brain tissues with looking for Tiger presence in the Lewy bodies, and the brown staining, it means that the antigen found the presence of that protein in the Lewy bodies. So these are brains from patients with Parkinson's disease, also in the substantia nigra. And as you can see, this is this neuron, and this is a Lewy body that is stained positively for Tiger. So we found that in different tissues from different patients with Parkinson's disease, and we possibly show that not only in the zebrafish model, we also found Tiger is present in the brains of patients with Parkinson's disease. And you also saw it was overexpressed in the neurites of these neurons of these patients. We are also looking at different synucleopathy that is called dementia of Lewy bodies. You can see here it's also this is not Parkinson's disease. This is dementia of Lewy bodies, and it's also present. Look here, if you can see, it looks more reddish here, but that is a positive staining for Tiger in dementia Lewy patients. We also wanted to see if it was correlated to alpha-synuclein. You know that alpha-synuclein is present in Lewy bodies and is also pathognomonic of Lewy bodies. And we have different stainings with immunofluorescence, trying to find if Tiger was also correlating with alpha-synuclein. First, we have the staining using normal histochemistry with that's staining for Tiger. Here you can see here is the halo. We use the same tissue and stain it for presence of alpha-synuclein, and it's here you can see here is correlating with Tiger in here in both cases, here and here. You can see also this in the neurite. To really confirm this finding, is we did we stained serial tissues. So the four consecutive tissues were stained with either Tiger and alpha-synuclein to say that to see if they were correlating. And you can see here is one Lewy body with Tiger, and this is one Lewy body with alpha-synuclein. The same here, Tiger and alpha-synuclein. So we possibly corroborated that. This is a very complex project. I only did a brain tissue or a pathology tissue. I also did have cellular models where I did study the cellular mechanisms that can be involved with Tiger. I also did cloning, having this conditioning models for that to see how affecting the gene expression of Tiger in different conditions can be involved in the pathophysiology of developing the disease. I cannot show you those results because they are also still a little bit proprietary, but yeah, we have positive results that is still ongoing, the research. I left my PhD and that study is still ongoing. Yeah, I mean, I hope I can see more results from my previous lab work from them and showing Tiger in not only Parkinson's, but maybe in other conditions. So I finished my PhD. I returned to Mexico. I was trying to find again my roots being a doctor. I was a researcher for 5, 6 years, and I was still teaching in the UK. I had chance to continue teaching medicine, also teaching neuropathology. It was something that I really like. I found out I really like pathology, and I also thought of doing like another residency in pathology. Is just very interesting, and it's very relatable to genetics. So yeah, I continued working, and I got another offer when I was doing my when I was working in Mexico to do a postdoc for Baylor College of Medicine, and that's how it brought me here. And I continue working in neuroscience, and we studied this other molecule that is involved in neural tube defects. And long story short, because I know it's very late already, but we found out I helped staining the tissues of these different mice models to to understand how it evolves with the different pathology for this condition in mice with mutations in this particular gene affecting the development of the neural tube and the closure of the neural tube. And we found really good, exciting results about how it's involving in the embryonic midbrain malformation and failure of closure. As you can see here, these mutants show that they have proliferation defects. Key 67 is a marker of proliferation. Also histone, phosphohistone. Okay, so I'm going to finish there. I have a new role now. I move again from basic research. I'm still doing some research here, basic research, but I'm more doing clinical trials, working projects, writing projects, enjoying life, enjoying Austin, enjoying Texas, enjoying being not only a researcher, not only the part of me being seeing patients, not only my clinical role, but also enjoying having my different hobbies. I really enjoy running. I've run several have marathon. I'm going to do an ultra, and keep my life busy, trying to because that helps me with my work. I have a very demanding job, but I really love it. I found out during time that you really need to love what you're doing and enjoying what you're doing, because that can also help with the outcome of all the projects you're working on. So I'm happy and I'm blessed that I found this new role. I'm a research associate. I work different projects in the neurosciences. I work with epilepsy. I work with neurofibromatosis. I work with neuroimmune disorders. So I have I am lucky in terms of, like, I found uh, a very good place to work with, a very wonderful team, wonderful colleagues. I mean, I cannot be more happy with well, I can be more happy, but I think um, now I still hear the call of I still want to see more patients. I see them, but I'm not a doctor, I'm not a treating physician, but I still hear the call. Mainly after 2 years ago, my dad died, and is that kind of things start to resonate with your soul and start to think, "Oh, well, I don't know, I wasn't there. I probably should have done something. I'm the doctor. I'm the doctor of the family." And that is when, you know, you start to think about what to do next. I think my motivation in life has been always my family. Losing my dad also helped me keeping my focus on what I want to do next. And also what we here for is helping others, no? Helping people, not because it's in your nature and your soul and something that you really want to do. So yeah, thank you very much. I hope you enjoy my little talk. I don't know if I help in any way. I hope I did. But yeah, thank you.
Yeah, thank you very much. That was a very great presentation. Learned a
Thank,
lot. Very interesting as well.
thank you. Yeah.
Okay, so does anyone have any questions they would like to ask? You just type them in the chat or you can unmute yourself and ask them.
I have a question. So, I love just like how much like you just keep yourself so busy. Like it seems like you're doing everything all at the same time, like all of your hobbies, along with all of your amazing research. And I have two questions actually, and was wondering like how do you manage to balance it all, just like with your home life and all of that? And is there anything that you've learned, like any like anything that you've learned in your studies that you kind of carry into like your normal life? Like I was just curious about that.
Yeah, no, thank you for the question. Um, it is, I always say it's like sometimes it's like a superpower, trying to multitask many things at the same time. But also can be something that can be against you. So I think I learned to know my limits. That's what I was saying. Most of the time is because you find what you like. Like my balance, for example, is like, okay, I have my day work is I start at 7, I finish at 5. Um, I need to go with that in a religious way, because I found out when I just working, I wasn't even enjoying working. I wasn't even happy. I wasn't even, that balance was not in there. So I started thinking, okay, I don't need to work 10 hours straight. I don't need to work 7 days nonstop. I need to enjoy life, and I need to put limits on, like, okay, how much is the time I can manage to do my work and do it well and not doing something that can be wrong or like something that it won't be like even useful for anybody. And so I started to think, okay, I think I can do my 8 hours, 5 days a week, and then I need something that help me. And I started doing meditation, and I started to know myself better. I think that's the key point, like to know yourself better, because not everybody is the same. I mean, I have my family that is my mom, my sisters, my brother, but I don't have kids. I am not married. So I think sometimes that for me is an advantage because I know my times, I know what I can handle. I I have friends and I have also my social life, but it's knowing yourself, knowing what you want, and also start slowly, not doing like everything on the go. Like, y- yeah, I think it's finding that point where you feel good with what you're doing and enjoying, loving it.
That's really beautiful. Thank you.
Thank you.
Does anyone else have any other questions? You can type them in the chat as well. There's no questions. I actually have a couple questions that I would like to ask.
Mhm.
So you mentioned a bunch of like the subspecialties within like the broader topics. Do you know which ones you were like you personally were particularly interested in?
Yeah, neurogenetics. Really, I enjoy when I was doing my specialty degree. You have to rotate with these different subspecialties, and neurogenetics was the one that I always was interested in on the brain and neurology. Yeah, that one was one of them. Metabolic conditions, metabolic disorders. Those two were my main ones.
That's cool. In like your journey, did you have any like regrets or things that you might have done differently?
It's funny that you asked me that. Yeah, I did. Because different at different stages of my life, I got rejected several times. Like, and I really, it's a feeling that you don't like, and most of the time is you feel guilty and you feel really bad about you. You start saying, like, punishing yourself because you didn't do what you needed to do and you were not good enough. But I think that's a part of the process of improving yourself. I think if I haven't failed at those different stages, I wouldn't be where I am now. One of them was not getting into the subspecialty that I applied. I applied for neurogenetics. I didn't get it. It was really a sour time for me, and that's when I started regretting why I did genetics. I could have been a surgeon, and I have like better chance of getting a job, and or like why did I leave Mexico, and now I am different stages are there are regrets. Um, Now, for example. Uh, Sometimes I regret leaving Mexico because I didn't have the chance of seeing my dad. I was here when he died, and he was still in Mexico, and I have regrets. I still do, because I came here and I wasn't there when he needed me. So because you're the doctor and you were not there for your family. So sometimes those are my regrets, but you cannot be everywhere, and there are things that you cannot foresee. Like, it's something that you have to learn to live with and to deal most of the time.
Yeah, for sure. We have a question from Temi,
Mhm.
and they were asking, when deciding to pursue research and seeing patients, do you think you are comfortable with the balance you have?
Yeah, I think I am now. At the beginning, I wasn't happy, because I had to lean towards one of the other. I I am starting to feel happy, but I I think I am one of those persons that want more. So I do have a balance now, but I want to continue because you never stop learning and you never stop wanting more. So yeah, I do have a balance. I am happy that I can enjoy my hobbies as much as I can enjoy my work. Yeah, I think, but it took me a lot of years to get where I am and a lot of learning.
Yeah, so this brings me into another question I have.
Mhm.
So right now in your life, do you have any like big future career goals or the next big thing in your life that you're trying to pursue?
Yeah, so right now I am a research associate. I do have some of my projects of my own, but um, I want to have I am I got a promotion recently, but I want to continue getting promoted, and my ambition in the future is having my own lab and my own research group. That's my vision in the future.
Yeah, that sounds very cool. We have another question from Mumenia. Sorry if I pronounced that wrong. They asked, were you the first in your family to pursue this
Yeah,
path?
yeah,
First
yeah,
one?
yeah.
Yeah. Was it hard, or do you think it was just something you just were interested in?
Uh, Hard for me to come
Yeah, do you think it's
like
like hard? Did you think it was hard for you to be like the first one in your family to do this?
no, no, I don't think so. At the beginning, it was hard when I was trying to do my master's. Because at that time I wasn't certain that I was going to get a scholarship. So I really wanted to get a master's degree, and I asked my family if they could help me funding if I couldn't get the scholarship for my master's, and they said no. That time was hard because they told me like, you already have your degree, you're already a doctor. Why you want to do this? It makes no sense to us. But that wasn't all my family. I actually had a lot of support from my mom and my siblings. So yeah, I don't. It was hard at that time, but not too much. I'm a dreamer, and if I want something, I fight for it. And I think that's something that you have to have uh, that um, that fire on you, like the fuel. Like, yeah, I think.
Yeah, that's for sure. You really need that motivation to get you going. Um, if does anyone else have any questions? If you guys don't have any more questions, I can just wrap up the presentation with an ending slide.
I actually have a question of my own. Yeah, so I'd like to start off like that was a really, really great presentation. That was amazing. So, how do you think the fields of neuroscience and genetics would change with like evolving technology in like say 5, 10, 20 years?
Yeah, actually, I think they are changing really fast. When I started, I didn't think we would be having like treatments, for example, for genetic conditions, for example, SMA, spinal muscular atrophy. And now we have gene therapy. And that's really amazing because that makes a difference in terms of like this baby is going to live, or like this baby is going to walk, or like um, other conditions such as, for example, Niemann-Pick's, like that that is not a cure, but it's going to improve their quality of life. They can speak more, they can stop like the neurodegeneration more. And also, if you like, most of the time, like I always try to say this, we don't when we have problems getting treatment sometimes because we don't know the pathology. I mean, we have Parkinson's. Parkinson's is a very good example of it. We know what is Parkinson's in terms of like this is a neurodegenerative disorder that is the neurons in the midbrain start to die, and then we start having all the symptoms that finally get to the stage that you get a disease, and then you have like the outcomes we have. And why the neuron starts to die, nobody knows. We have different genes that have been involved. We know the function of the genes, but what do they do in the brain? We don't know. It's most of the things we don't know. I think that's where we are going now. It's like we don't know, but we are going to know because we have these different technologies in terms of like looking into maybe having better models, not solo just cellular models, but also like organoids that can help us like um, uh, having a better picture of what is going on in the brain that triggers the disease. Diagnosis, I think it's going to go very well. And another one is like we have gene therapy. We also have something called antisense oligonucleotides. That is also new therapies that you can give to patients with genetic disorders, and that can also help stopping in a way the neurodegenerative disease. And also diagnosis. Sometimes we don't know. We have the patient, we think they have this specific condition, and all the results are negative, and we don't know. Like you exhausted all diagnosis tests that you have on hand, and you still don't know. But as much as we know, like from introns, from exons, from epigenetics, like that's I think it's going to change soon.
Yeah, so if anyone has any more questions, they could ask it now. Okay, I don't think anyone has any other questions. If you have like any questions that pop up when I'm like wrapping up the session, feel free to just unmute yourself or ask it in chat and I can pause. Okay, so let me just pull up the ending slide. Okay, so after the session, we kind of ask you to reflect on like what brought you here to the session today, and maybe what are the three major takeaways that you got away from this amazing presentation. And also, we would like you to reflect on like what you would want to learn more about and conduct sort of that research. If you also want some recognition on your work, like your articles, maybe some reflections, like the reflections that you should be doing. If you want to like write it out on a document, you can also submit it to our blog, and it could get published on our website. You could also submit things like reviews or success stories. And again, if you're interested in being part of Pre-Health Shadowing, we have a volunteer team, and we also have a team member team, and you could all apply to these through our website. And again, if you can, please donate. We really want to keep this program free and accessible to everyone. And if you know anyone else who may be interested in donating, please reach out to them. And this is the part that everyone's been waiting for, our digital quiz to get your certificate of shadowing hours. So how you would do that is you would go on our website, and I think you guys have access to this because you guys probably accessed the link through the website. Under there, there'll be a page that says like take the quiz. And essentially, it's a 10 question multiple choice quiz based on like this presentation. You will have like two chances to pass with a 70% or higher for verification of your virtual shadowing hours. And quizzes are open indefinitely for your convenience. So don't stress out if you have something later to do today. It's going to be up for a very long time. And after that, make sure to press finish this course, and then you can download it, and then you will be able to download your certificate. And after the session, give it about like probably 5 to 10 minutes, and then the quiz will be up. Also, if you like happen to get off some like your computer crash or something, you missed a part of this presentation, or you would like to like review some of the stuff for the quiz of the session, feel free to go to our YouTube channel at Pre-Health Shadowing to watch any of our previous sessions for free. This includes this session as well as previous sessions, so you could watch previous sessions and also go take quizzes on those. And yeah, also be sure to join our email list and also follow our social media so you can catch our sessions every week and now and then. We have a bunch of sessions coming up. Yeah, so thank you for joining pre-health shadowing. We will see you next time. And if you have any questions, feel free to stick around. You can ask me or the student team. Yeah, thank you.